Okay, good afternoon. And yes, we are recording. Hello, doctors. My name is Leanne. Welcome to another session. Today, I'm sorry that I'm moving around. I'm going to be using my phone, which is much better. I just want to make sure that you can all hear me, yes? Let's see, just a few yeses, maybe. I know I had tested it earlier, but just to make sure everybody can somehow hear me. No? Okay. The sound is not as clear as it was the previous time. You can hear me? Can hear me clearly. Okay. Okay. Thank you so much for joining the session today. For those who don't know me, my name is Leanne. I am recording this so that for those who cannot join us, they will have a chance to review this material later. Just a brief disclaimer. I just have to read something out. So I am not here to discuss any cases in the USMLE or GMC exams, including the PACES, MRCP, MRCS, or the PLAB. And so the purpose of this group is to share knowledge on patient management. So we are here to help one another to become better doctors by identifying where we go wrong in patient care. So thank you for joining. For the first session, I gave an overview on the PLAB exam as per their website and discussed a few things on the mistakes people make, not only on this exam, but just as general practitioners. So today we will talk about the challenging patient. So the challenging patient is a pure test of your communication skills. So this test is just to see how you can react in a stressful situation. And so they will really challenge you to see whether you will lose your words, whether you'll get frustrated, or whether you'll break down and cry. I'm sure they've seen it all. But I would want you to hold it together until the end of the station, or until you can get maybe further help from someone who has more experience. You have to be a good listener in this station. The patient encounter can go bad if you don't listen, and the patient will be triggered by specific words or specific questions that show you're not listening. For example, if you don't get the name and you say something like, "What was your name again?" or "Why were you here?" or "Can you please repeat that?" The best way to deal with some of these challenging patients, because they want to talk, let them talk, let them finish. Listen to what they are telling you and then reflect it back to them. "Doctor, I am very angry." "I can see you are angry." "Doctor, what is going on with this hospital? Is everybody here incompetent?" "I'm sorry that you think that we are incompetent. Please tell me why you have these thoughts." So you literally listen to whatever they're saying and you reflect it back. Pick a word and reflect it back to them. And then once they calm down, then you can probably proceed. Okay, so don't interrupt the patient. Let them finish. If you are talking and they interrupt you, you need to stop. If they insist and say, "No, you go ahead, doctor," you say, "No, please, let me hear what you have to say first, and then I will continue." So this is the listening part of the communication skill. And another skill you need when going into the NHS hospital or the NHS clinic that has a challenging patient is the non-verbal communication. So really watch how your face reacts to whatever they're saying. If they say something surprising, don't look surprised. If they say something concerning, look concerned. If they say something happy, well, it's for another case, look happy. So you kind of mimic them. But with the angry patient, it is best for you to have not a blank stare, but almost like I'm really listening, like a sad, almost saddened stare. Maintain eye contact, but don't stare at them. So this is how I try and maintain eye contact. I look at them for a couple of seconds, and then I look to one side of the wall. I look back at them, and then I look to the other side of the wall, and then I look back at them. But you have to kind of time it so you're not like, almost like nystagmus. You have to kind of time it so you don't stare, because then that is also rude, So look at the face. If you have to look at your hands, look back at them, look at the side there are very many places you can look at when an angry patient is trying to verbalize their feelings. If a challenging patient is trying to communicate something that is really disturbing them. So these two things, you have to be a good listener and watch your non-verbal communication. Then also pay attention to their non-verbal communication. The same thing, their facial expressions, their hands, just pay attention and reflect back. You have to have a certain level of confidence while entering these stations with the challenging patient. Of course, be open-minded. Don't enter the conversation expecting a specific outcome. So be open, like, to listening to their point of view, rather to racing to get your message across. Really, people can tell if you don't listen. So listen in these stations, okay? All right. So I made a couple of notes here. I collected actually a couple of guidelines that will help you deal with these challenging patients, and we'll go through them one by one. Don't give false reassurances. The statement "do not worry" is really, really bad. Maybe you should really try and change it to say, "I can see that you're worried." But if someone is upset with you, just say, "Don't worry, I'll handle it. Don't worry, we have the best care here. We'll take care of it. Don't worry, we'll look into it. Don't worry." Don't use the word "do not worry." If you do not know how to answer, for example, if the patient says, "Doctor, what is going on?" Don't lie, or don't try and make up like a fake diagnosis. You tell them the truth. Tell them, "You know what, I have asked you many questions, and thank you for answering them. I have also done a physical exam, which at this time is normal. Let's run some more tests to further investigate what is going on." But don't try and fib a diagnosis or give a false reassurance. For a challenging case, you give a definitive diagnosis only if you have confirmation tests. So a patient maybe who is presenting with cough symptoms, flu-like symptoms, and you're suspecting this may be the acute phase of HIV. If they ask you, "Doctor, do I have HIV?" you can't give a confirmation about this until you see the tests. And that's why sometimes when I'm speaking to the patient, I'll give my investigations before I give the diagnosis. So I'll say, "At this time, I've done the physical exam. Thank you for answering all the questions in the history. In order to get a better picture, I'd like to do some investigations." And then wait a little while for the investigations to return, for like 1, 2, 3 seconds. So if you're in a scenario, don't break the patient doctor communication to look to the side to say, "Oh, do you have any investigations for me?" or "I'm waiting for them." You can just slowly say, "You know what, I would like to maybe do this test, And I'd like to do this test, like slow down your communication so you can give a chance for the results to be given to you by the examiner. Okay, this is just the background information about the challenging patient. There are so many different challenging cases. I just wrote a whole list down. So I wrote down the patient who refuses care, emergency cases, dying or deceased patients, terminal cases, HIV or cancer, difficult family members, the angry patient, the one who wants to leave, the one who ran away. And maybe we haven't seen such cases, but these patient scenarios are evolving. So we also have to evolve with the way the patient scenarios are evolving. Confused and anxious patient, the abused patient and the abuser, the malingering patient, the wrong patient, the one who is demanding medications. I don't think we'll get to all of them right now, but I think I'll have to make another video about the challenging patient. Okay. So I'm sure in practice you've dealt with a patient who refuses care. So this person has maybe been dropped off by the ambulance, and after the investigations, you found out that they are bleeding. Or they have a bleeding ulcer, or they are hypoglycemic or hyperglycemic, or they don't want life-saving surgery, or they don't want IV fluids, they don't want blood, they don't want insulin, they don't want any life-saving medications, they don't want IV antibiotics. This type of patient, you don't want to give them the option to leave so fast. So they will kind of be like an irritated, angry patient. So they'll try and say, I have so many things to do. I have an office I need to go to. I have children at home. I have a dog that is home alone. I have a wedding. I have children to pick up. This is almost like a social case. If you're invested in what they have to say, then they will be invested in what you have to say. For example, if I tell you, doctor, I know that my blood pressure is 80/40, and I need to have IV fluids, or I'm almost getting into some sort of septic shock and you have to give me antibiotics, but I have to go home. Yes, you have to get to management of the case, but get invested. Why do you need to go home at this time? Is there anybody you can call? Is there a friend? Is there a family member who can help you at this time? If you can give us permission, we can organize with a social worker to arrange how your child can be picked up from school. We can arrange with some of the animal services. I don't know what they're called in this country. They can go and take care of your dog and maybe put your dog in a shelter until you come back. Oh, you're planning a wedding. That is very interesting. Congratulations. What day is the wedding? So you have to be really invested. Just don't say, okay, all these things are happening to you. We need to give you this medication. You have to also show that I care about not only your disease, but I also care about you. Is your fiance around? Does he know you're in the hospital? Do you have some bridesmaids who know you're in the hospital? Can somebody take over the plans for the wedding at this time? And then if they really want to go, you really have to try and convince this patient. And sometimes I scare them just a little bit. For example, one who needs antibiotics. You say, you know what? Some of these bacteria are really, really, really aggressive. Once they get into the blood, they really can go and damage other organs. For example, your kidney, your liver, even your heart can be affected. You could have come in with a small infection, but because we are not treating it, in a couple of hours, you can really be in a dangerous situation. Your life can be in a lot of harm Your situation can really change. Now you're talking to me, and I'm glad that you're feeling okay, Mrs. James. But your blood sugar is still very unstable. I would hate for you to go and collapse. It would make me very sad if we did not manage your diabetes appropriately, and then you collapse in your wedding. It will be a sad day for you and a sad day for everybody else. I want you to go into your wedding feeling confident that your disease is managed. This is how you convince these people, and still, if they refuse to stay in the hospital, then you say, okay, I can see that you're very concerned about your dog, about what you need to go and do at home. I can see that you're very concerned. Please, before you make a final decision, kindly give me a few minutes to have one of my seniors come and speak to you, to have one of the consultants come and speak to you. Kindly give me a few minutes to let me run a couple of tests to make sure that you are okay. And if you really want to go home and you feel sick, you have to do safety netting. Find a way. If you go home and you start feeling dizzy again, if it's hypoglycemia, just take something small like some orange juice or some carbohydrates, some sweets, and then call the emergency services. You are very lucky that you made it to the hospital at this time. I really would not want you to go home without us having treated you completely. And if you still feel like you need to go home after the consultant speaks to you, I'll have you sign a form that you're leaving against medical advice. Okay? But I hope you would consider or reconsider. All right, I've exhausted that one. The patient who refuses care. A little note I wrote here was, I would say to them, right now, staying in the hospital is in your best interests. But before you make a decision, yes, please talk to the consultant. But it's in your best interest right now to stay in the hospital. Okay, challenging patient number 2, the emergency case. So you're in the NHS hospital in London or in Manchester, and the patient comes in, and you go in and you introduce yourself to the patient, and they're looking like they're really not paying that much attention. When you walk into the room, you don't know what to expect. So you have to be on guard and very alert to the symptoms. Okay. Hello, my name is Dr. Washira. Can I please know your name? Oh, doctor, I'm not feeling well. Oh, doctor, I'm not feeling well. Okay. Are you able to talk to me? Doctor, I'm not feeling well. I'm really feeling sick. I'm really feeling sick. Okay. I'm concerned that you are not doing too well right now, and I'd like to check your vital signs, your heart rate, your blood pressure, your oxygen level, your temperature. Oh, you can't hear me? Oh, can you hear me now? I'm so sorry. Can you hear me? No? You can you hear me?
Yes, I can hear you. Yes, I
okay.
can.
Yes,
okay.
we can hear you, doctor.
Okay. Sorry. Just adjust your headphones. Oh wow, I was really into that case. Okay, yeah, a patient who's really not feeling well. You do not know what is happening to this patient. It could be low blood pressure. It could be asthma, like an acute asthma attack. It could be anything. So let your vital signs cover everything. Mention them. I want to check your heart rate, your blood pressure, your oxygen level. I want to check your temperature to see if is it sepsis. And then a crucial one thing I call a vital sign is the blood sugar, because you can have everything else normal, but it could be the patient could be having hypoglycemia, and you don't want to catch a blood sugar of 1.2 after 2 minutes. No, so ask for it earlier on. I want my vital signs and I'd like to see a blood sugar. So just get into the habit of doing this. All right. So And then tell your patient, I'd like to ask you a few more questions, but I would want to stabilize you first. Let me stabilize you, Mr. James, and then I'll ask you a couple of more questions to see what is going on. So you've asked for your vital signs. You look at the monitor. Has anything improved? No. Then you do an intervention. After you do an intervention, back to the patient. How are you feeling now? I'm not good. Back to the monitor. It's literally like a triangle. The monitor, intervention, the patient. The monitor, intervention, the patient. So that you will not be surprised by the patient dying. Because you will look at the monitor almost 3-4 times in a minute, and you will adjust your interventions appropriately. So if he's having, for example, a pulmonary embolus, okay, you're short of breath. All right, I'm going to, can I ask you a few questions before I give you oxygen? Do you have any lung issues like asthma or COPD? No. Do you have any allergies? Because I'm thinking ahead, I may need to intervene with some medications, and I don't want to ask you then before I intervene. I'll ask you now. So do you have the smoker's lung? Do you have any medication allergies? All right, let me stabilize you first, and then I can update you on what's going on. Monitor, I'm looking. Okay, 2 large bore IVs. Let's hang the fluids. Let's give the oxygen appropriately, Venturi mask or high flow oxygen. Back to the monitor. Oh, your oxygen has improved, Mr. James. How are you feeling? I'm not feeling too good. The blood pressure is... So that's the triangle I'd like you to have. Patient, monitor, intervention. Patient, monitor, intervention. You do it 2 times. You say, at this time, I would like to update my consultant on what is going on. Because if you are a consultant and the patient, you just had a case, let's say, let's pick an OBGYN case, for example, and this woman is bleeding out after a vaginal delivery where instrumentation was used. And the FY2 calls you after 6 minutes, this patient has been bleeding out. Come on. You want to say, at least I've started my management. I would like to have the consultant notified that this is, but I will continue with my management. Okay, all right. So never forget, with emergency cases, patient is here, monitor, intervention. Patient, monitor, intervention. After 2 times, you're letting the consultant know, but you're also saying, you know what, I've called for help. I'd like my consultant to be made aware that this patient is bleeding profusely, or that we have a patient with status asthmaticus who's in the emergency room, but I will continue management. All right. Let's see, the third case. And I'm sure we will encounter this type of cases working in the NHS hospital. The abused and the abuser. So you take the history. First of all, the look for, really, like in a case with suspected abuse, you have to really zone in on the patient. The patient will be very withdrawn. The patient will be a little reluctant to answering your questions. So you have to step aside and say, I can see you're concerned. Are you concerned about anything else? I know you're saying that you've come in with a headache, or you've come in with dizziness or lack of sleep. I know you've come in with this main complaint. I'm sensing that something else might be going on. Okay, and then now they'll say, oh, doctor, all these things. Okay, if the patient at some point, let's say it's a mother who has brought in a child who's been abused, they will ask you this question. So you think my child is being abused? This is a very confrontational question. So do you think this child is being abused, or do you think I'm abusing my child? My apologies, Mrs. Jones. If it seems that I implied that you are abusing your child. My primary concern is about the safety of your child. Or if abuse is to them, you say, my primary concern is about you. My goal is to make sure that you are in a safe environment at home and that you're not a victim of abuse. In any case where you suspect abuse, I would verbalize this. So you say, I'm primarily concerned. So you think I'm abusing no, I apologize if I implied that that you may be doing any harm to your child. But right now, my primary concern, even you see the hand on the heart, yeah, I'm primarily concerned about the safety of your child. And my goal is to make sure that he is safe at home, or safe with the babysitter, or safe at the school, okay? And that they are not a victim of abuse. At this time, I would like to involve social services to help investigate in this matter. Doctor, is it really necessary to involve social services? They might take my child away. I am sorry, madam. I'm sorry. Don't say madam if they have told you not to call them a different name. Just call them once. I'm sorry, Mrs. Jones. I have to involve them at this time. Let them help investigate, and let us help make sure that your child is in a safe environment. Abuse child. The one who is demanding medications is another challenging patient who you might find in the NHS hospital or in the NHS GP clinic. All right. The one demanding medications can appear in different ways. So you have to be very careful. They could be demanding medications because maybe they used them in the past and they need them now, but the scenario may not be appropriate. For example, somebody says, I had a cough, a bacterial cough, an upper respiratory infection, and I was given antibiotics. Now I want antibiotics. Or somebody says, I was given pain medications and it's been 1 month and now I still want the oxycodone. Or somebody comes in, this was actually one that I encountered, where they're coming in from a different hospital and they want a refill of a medication that was ordered by another doctor, for example, a narcotic or a sedative. Okay, so the ones demanding medications, there are a variety. I wrote some down. So the one who wants a refill, the one who is insisting for narcotics, the one who wants you to support them to get a week off from work, so they want you to write a sick note for them, and they're still they have no physical symptoms to warrant the sick note. So they are almost like a malingering patient. But you have to be careful because some of them, for example, with pain medication, pain is whatever the patient says there, but you have to do a really good history and physical. Okay, let me talk about a case, for example. A patient comes in and says, I have leg pain and I want you to give me narcotic medications. I want you to give me fentanyl or oxycodone. I would say, of course, after you've done all your maftosa, like what I'm talking about is just like the management where you would get a better rapport with this patient, or in other words, better IPS points. I would tell them, okay, Mr. Smith, there's a process I have to take before I order any medications. Anyone asking for medications inappropriately, you want to say, okay, I hear what you're saying. I can see that you're in pain. From the questions that you have answered, I can see that you have been suffering with this disease for a long time. But there is a process I have to take before I order any medications. It is not appropriate to just give medications without a full investigation. And this involves me taking a history and a physical exam. So I have taken if you would like me to investigate what is going on with you, I would like to ask you a couple of questions, and I would like to do a physical exam. Okay, but without these things, and maybe even some investigations like an X-ray or some lab work, I still would not be able to order medications for you. Okay, then you go on to say if they keep insisting, no doctor, I don't have time for you to do a physical on me, I don't have time for you to ask me all these questions, just give me the pills, I need to go because I'm running late for work. Then now you get into more of why it's not appropriate to order this medication. So some medications may be appropriate for others and dangerous for others. So for example, maybe a guy was playing rugby and he hurt his leg, and his friend had some medication in the house and he took those pills. And now he comes and he says, I want those same exact pills. Can you order me these pills? Then now you have to still tell him there is a process that we have to take before we order medications. All right. And then if he's insisting, then you say some medications may be appropriate for others and dangerous for others. I do not know why the medications were ordered for your friend. So before the doctor gave the medications to your friend, there was a checklist that they went through in order to do them. I would have to do my own checklist to make sure that it's appropriate for you. And then you can give a few examples. Okay, for example, if some medications are taken on an empty stomach, they may cause ulcers. Other medications can cause drowsiness. I need to find out if you're taking even some herbal therapies which can interact with these medications. No, doctor, I want you to give me these pills. You're wasting my time telling me that you want to do a history and you want to do a physical exam. Okay, I can see that you are frustrated. So don't ignore the patient, and also don't try and push them, but try and make them understand. Some of them can ask for sleeping pills, and it's not appropriate for them. Some of them can ask for, but most of them will ask for maybe narcotics because maybe they took from somebody else. Just be a bit careful with such a patient, because in fact I wouldn't even want to get into the argument with them without first finding a history. So why did you take these pills? Did it help you? What type of side effects did you see? When did you take them? How much did you take? Have you ever done this before with any other medication? And then now get into the reason why do you want specifically this medication. Okay. And of course you can just tell them, what, some of them just have some really bad interactions, and in the end, if they really refuse, and you say, what, it's not my call to order this medication to you. I will have one of the senior doctors come and speak to you a little bit more. Maybe we can offer you something else for the pain. Maybe we can offer you something else for your insomnia. Maybe we can offer you something else for the anxiety. So if you get into a deadlock with a patient, and a deadlock meaning you're not getting anywhere, that is when now you call for help. You say, okay, I can hear your concern, but I'll have the consultant come in and talk to you about this. Okay. All right. The one who says, I want a sick note, or they want you to support them with a letter for insurance. Maybe they got injured in a car and now they're back, and now they want you to write a letter so that they can take it to the insurance so that they can collect money, or the one who wants a sick note so that they can get time off work. All these cases are very social. So if you spend time focused on the social part of the patient, why would you want this? Have you tried something else? Have you tried other interventions? Did they work? Now you're coming to me, and really, we do not find your sickness warranting a sick note. Or you can say, I wrote something, I said, okay, I don't find your disability really, really significant to keep you out of work. And then you can explore a little bit more the social aspect. Why don't you want to go back to work? Do you like your job? Are you frustrated at work? Have you considered asking them for time off? Have you considered taking some vacation time? This is how I'll deal with this type of patients. Okay, another one. Patient, I don't want to tell my partner that I have this disease, that I have sexually transmitted infection, that I have HIV. Please acknowledge that it is difficult for them. So you can ask different ways of acknowledging that it is hard for them. Then, okay, I can see that this is difficult for you. Please tell me why you would not want to notify your partner that this is happening. Okay, doctor, I feel like they are going to leave me. I feel like they are going to kill me, or all this. Why do you think they will leave you? Why do you think they will harm you? So this is that reflective process. You really try and practice over the next couple of days if you have time. Whatever somebody says, you pick the last word or a word in the middle, and then you reflect it back at them. For example, for example, let me just use something. I like blue cars. Oh, I see you like the color blue. Or why do you like blue cars? So just try and practice this whole reflective kind of speech. It will really help with dealing with these challenging patients. Okay. Let's see. Where is another good ethical? Does anybody have any specific question that they have at this time? I know I had said I would ask if anybody has a specific question on ethics. Let me just check for 2 seconds if anybody has anything. Okay. Oh, breaking bad news. All right, good. I got like an inbox on this. Oh yes. Let's deal with the breaking bad news cases, because these are also challenging patients. All right. How I was taught to break bad news is, if you break the bad news, there are different methods. Spikes, make sure the setting is right, and how much do they want to know? Do they want somebody to be with them? Okay, that's fine, but it can be very robotic. When you're breaking bad news, for example, some of the cases that I have dealt with in the past, you want to find out the story that happened before the incident. For example, if somebody, a father wants to know a son wants to know if his father, if the surgery went well, and let's say there were some complications in the surgery, complications like a stroke, or if there was a lot of loss of blood, or now that they can't come out of anesthesia. Doctor, I'd like to know what is happening to my father. I was called from work that he had a heart attack, and already as the doctor that, he went into surgery, or he went in for some interventional procedure, but now he has a stroke, or he's on the ventilator now. Oh, okay, I can see telling about cancer diagnosis like breast, lung, or cancer. Okay, good. I'll get into that. You want to find out, okay, so what happened? Where were you when you had the bad news? Okay, I was at work. I was busy working, at the, where do you work? What do you do? I'm an accountant. Because this is the thing. When you're in the room with a patient, you're dealing with two patients. You're dealing with the one who's sitting in front of you, and the imaginary one who has suffered the bad event. So you have to treat both of them. This one is telling you, my father came in here with a heart attack, or he came in with a stroke. I don't know what's happening. All right. My name, of course, is Dr. Washira. All right. Can you please tell me a little bit more about your father? Okay. How was his health before all this? So I would do like a history, just a little bit about the father, just a bit, and then ask the son. And how has his health been? How have you been coping with his disease if he has been dealing with a terminal disease? Or have you ever seen him this sick before? And I can see that right now you are worried about the outcome. Is there anything in specific that you would like to know? You will know that in a breaking bad news case, they will ask you the question, is he going to die? You have to be prepared for this question in the NHS hospital. Am I going to die? Is my father going to die? Or will he have future damage from this stroke? Will he be able to walk? Will he be able to talk? The best answer for this is, we are hoping for a good outcome, or we are hoping for the best, or let's give it time. But usually that's what I any patient who's asking for a direct answer from me, especially with a breaking bad news case, I hope for the best, maybe because I'm very optimistic, but it's a good answer also because you also do not know the outcome. Okay, so we are hoping for the best. Can I ask you a couple of more questions about your father? Okay, has he had any hospitalizations before? Has he had any surgeries? Is he on any medications? So you're prolonging the breaking of the bad news, because after you're done with your history of presenting illness, the chief complaint, history of presenting illness, then now you have to say, you know what? No, you don't say, you know what? You would say, okay, the news that I have is not very encouraging, or I may not have good news for you. We took him into surgery. They did the procedure. And after the procedure, we noticed that he was not responding well. He is now on the ventilator, or he now had a stroke, or he had the heart attack. Then stop. You're counting 1, 2, 3. You need to give them time to take it in. And you also want to see their reaction. Some of them may break down crying, and this means now you need to give them a little extra more time. So I would count another 3 seconds. 1, 2, 3. Are you okay? I see that this news has greatly disturbed you. Is there anybody you would want us to call for you right now? So even my talking kind of slows down, because you want to give them a chance to vent. Okay. So if they say, okay, doctor, so what does it mean? What does it mean that they're on a ventilator? What does it mean that they have a stroke? What does it mean that they have a brain bleed? Then we say, okay, I can explain it to you. This is now when you explain. Don't say, okay, he has a stroke. This means that he has lost perfusion to this side of the brain and blah, blah. No. This is where now you really wait. And the silence can be very uncomfortable, and I've felt this uncomfortable silence, but I would count 3 seconds maximum. Even when I'm talking to a patient and I'm quiet and they're quiet, I count 3 seconds and I say, is it okay for me to go on? Yes, doctor, you can continue. All right. So when we took him to surgery, sometimes we have complications that we expect. One of them is this complication. And also, if you forget, what type of complication that they have, then just say, you know what, I'd like to refer to the patient's notes. I'd like to refer to the notes, so that you're also not giving information that is not true. For example, if the notes are saying that the patient has suffered an ischemic stroke, and you forget, my goodness, what type of stroke did this patient have? Then you instead of saying hemorrhagic and it's not, you want to say, you know what, let me just can I just refer to these notes? It says here that he has suffered an ischemic stroke. So the information that you're giving them is the truth also. What are we going to do? Is it going to be okay? We are hoping for the best. And I know that the consultant would like to come and sit with you and speak to you more about it. Okay. The breaking bad news station is if you're talking to two family members at the same time and they start talking to each other, you want to let them talk. You don't want to interrupt. If they're crying, you don't want to interrupt. If they look down, you comment about them looking down. You say, I can see your concern. Please, these are the little cues that where I find most people are missing points. They're not picking up on the patient cues. Okay. All right. Please don't give interventions that an expert would give. So if the patient has a subarachnoid hemorrhage or a really big brain bleed, don't be tempted to give information about what the neurosurgeon would do, because you do not know. You don't know whether they're still doing burr holes now. You don't know whether they're doing whether they do open craniotomies now. So refrain from that. You say, you know what, at this time, a specialist or the specialist neurosurgeon will come in and will speak to you and will talk to you about further management. So don't be forced to give too much expert management. You need to care for the person who is in front of you. Can I call somebody for you at this time? Would you like for example, one of the cases I said, you know what, I can reserve this room for you and your family. If you would like to wait over here, I'll reserve it for you. And if you have any questions, I'll leave my pager number with the nurse. Please ask for me. My name is Dr. Wachira. Please ask for me and I can come and give you an update. All right. Another challenging patient, somebody has asked, how about cancer diagnosis like breast, lung, or skin? Even before we give these diagnoses in regular healthcare settings, we never give these diagnoses unless there's a pathology report. Don't be tempted to give a diagnosis about cancer, even if it is glaring at you and you know it is cancerous. If you see, let's say a bone X-ray and there are lytic lesions and they have hypercalcemia, weight loss, fatigue, don't fall into the trap of saying cancer. Even if, for example, the chest X-ray has a huge mass that is shifting the trachea to one side, with a positive history of the family members, a good percentage having cancer, positive smoking history, don't give the word cancer. I stay away from this because you cannot give a diagnosis in a short time of taking a history of 6 minutes as an FY2 with just a chest X-ray, even if they're coughing blood. How I handle these cases is, okay, you may have the risk factors, and in fact, you want to ask, because they will ask you, do I have cancer? Or why do you think it may be cancer? So you're not also stalling, but you're showing that you're interested to see the thought process of the patient. Why do you think it's cancer? Oh, my father had cancer, my mother had cancer. And say, okay, there are different risk factors that show towards cancer, but unless we have a definitive diagnosis, unless we take a biopsy, this is the only time I can give a diagnosis of cancer. Well, be it the breast, be it lung, or be it skin. Even maybe the way we learned in medical school, like squamous cell is maybe below the level of the lip, and is it basal cell is at the top, and squamous cell is at the bottom. Even if it is a melanoma that looks with rough edges and hyperpigmented, you can't give a diagnosis of cancer. No, please do not give a diagnosis of cancer. Okay, I'm seeing a medical error. If there is a medical error, you have to admit. And the thing is, if it's the medical error of somebody else, so for example, the patient comes in and let's say an EKG showed a STEMI, and the other doctor missed it. Or if there was a chest X-ray with pneumonia and the other doctor missed it, don't get trapped into saying that the other doctor had a mistake. Don't blame the other doctor. If it was your mistake, you apologize and you say, I sincerely apologize that I missed the error. The chest X-ray showed that you had a pneumonia. I took a look at the X-ray and I misinformed you, Mr. James, that you did not have a pneumonia and we did not start you on medications. And this has really inconvenienced you. I sincerely apologize. I have already taken the steps to enroll into a radiology class to be able to learn how to investigate this. I have enrolled. So not that I will enroll. So if you're calling, let's say a patient, you're calling them back, please come back to the hospital because I missed to see that you have an NSTEMI, or to see that you had some type of heart block. You say, I have already enrolled in this class, and I'm learning it. And one of my colleagues who is an expert in reading EKGs is already training me during his free time on how to read EKGs, how to read chest X-rays, so that I do not miss this again. Yeah. I have notified. When we make a mistake, we have a protocol that we follow. We also write an incident report. So you have to show that you have acknowledged the mistake. So I wrote an incident report, and what the incident report says is, this is what I did, and this is the adverse outcome that has happened. This incident report can help further train junior doctors or my colleagues so that nobody else makes the same mistake. Our unit also our team also has bi-weekly meetings where we talk about some of and multidisciplinary meetings where we talk about some of the mistakes that have been made, and we see how we can learn from each other and how we can rectify this mistake. Now, you don't want to start saying, okay, we're going to have a root cause analysis meeting. Like this type of things, if every single doctor is coming in and saying it really sounds scripted, just break it down and tell them exactly what is happening in these meetings. We discuss the mistakes that have happened during the month and how we can improve and how we make sure that we do not make these mistakes again. Okay. What I say, okay, someone has asked, can I say that cancer can be a possibility? This was my mentality when I went into this exam. I said I would not say the word cancer. I would not say the word cancer unless there's a pathologist report there. So you can say, your symptoms are being caused by a wide range of your symptoms can indicate a wide range of causes. Maybe you can say, cancer is a possibility. Maybe you can say it, but I decided that I would not say it at this point without a pathologist's report. Yeah. Okay. So we've talked about so many challenging patients. You can say at this stage, you can't say for sure. Okay, you can say that, okay, at this stage, we cannot say for sure. You don't want to have a definitive diagnosis in anything unless you have a high suspicion. That's why some of when I'm dealing with some of the cases, I do not give a diagnosis until I say, okay, thank you so much for answering all the questions I have asked you, and thank you also for the physical exam. This is now helping me draw a better picture of what is happening. Your symptoms could be caused by a couple a couple of things. Some investigations would need to be done in order for me to make a diagnosis. So, for example, I'd like to check your thyroid function test. I'd like to do a chest X-ray, and then you wait. Maybe they'll give you a chest X-ray that will rule it in, rule it out, or thyroid function test that will rule it in, rule it out. Once you get the lab, you say, okay, my suspicions have been confirmed. As per these test results, your thyroid levels, your thyroid hormones are high. So you could have hyperthyroidism. And then now I'd get into the management. We can manage hyperthyroidism in a couple of ways. We can start you on medications that will help decrease the activity of the thyroid. And I'll have the consultant come in and check the plan of care, or just go through this the plan of care. Okay. Another challenging case, somebody has said, how about a colleague who is abusing abusing drugs and coming to work, or who's coming in late, or who's forging documents, who is not compliant or just lazy. You don't want to start with accusing. So you want to first give a good picture and then a bad picture. So I'd say, oh, hello, my name is Dr. Washira. Is your name so-and-so? Because you want to confirm that you're talking to the right person. If they've forgotten, let's say, to give an antibiotic to a patient, you want to make sure, are you Dr. So-and-so? Do you know this patient? Okay, this is why I'm here. Are you Dr. So-and-so and you work on this ward? Yes. All right. How has work been? How long have you been working here for? Do you enjoy it? Have you been going for the in-services that they've been having on the unit? How have you been dealing with your patient assignment? Literally, for all colleagues, I ask these questions. For medical students, how are you doing with your medical studies? I remember my medical school days, it was challenging, but work hard, you will pull through. So you're giving them some encouragement on this. And then after you build the rapport, then now you can accuse. You can say, Dr. James, I have something concerning that I would like to discuss with you. And I really need to talk to you about it because it can influence patient safety. So you're talking to them not to accuse them, but because it can have a bad outcome on the patient. All right, what is it, doctor? Because they want to also show you that they're interested in keeping the patient safe. All right, I've been smelling some alcohol on your breath. Really? Of course, they're going to have that type of reaction of like denial. Really, you think you can smell alcohol on my breath? It's not alcohol, it's mouthwash. But if the scenario has said that this person is taking alcohol, you say, okay, I can understand that this can be a bit embarrassing to discuss. If it's laziness or if it's cocaine, acknowledge that this can be a bit embarrassing for you to talk to me about this. But I am really concerned. I'm first concerned about the patient's care, or the patients under your care who will be receiving your care while you are under the influence And I'm also concerned about your career. These are some of the things that will really ruin your career in a short while. Are you having any problems with alcohol? Or are you having any problems with cocaine? Okay, it has to be said clearly that this person is dealing with this, and then you take it from there. I'll have to continue this session on the colleague who who's having maybe a drug problem, because then now you have to treat them also like a patient, but you can't really go into all maftosa. You can't ask them about, are you on any medications, are you on all this, it's a colleague. So I'm just going to I'd ask them about any stressors. How have you dealt with stress before? Did it help? Have you tried just relaxing or taking a vacation? What led you to start using cocaine? What led you to start drinking alcohol? I know there are some colleagues of ours who drink alcohol, on their days off, but they make sure that they're sober by the time they come into work. What has led you to think that you can drink alcohol and come into work? This is now the path I would go through, because maybe they are going through a hard time and they're having a hard time dealing with the stress. So I would really try and build a rapport in this manner. I still have maybe about 10 other cases. There's one I really wanted to touch on. I know it's a new case. Like last time we talked about the new case with the patient with the mouth sores, and how you would manage them. And we didn't talk about it. I looked into it later on. You'd tell them to avoid really cold, hot foods, spicy foods, all these things, and then you would refer. You can refer them maybe to a specialist. I'm wondering who, a dentist. No, wait first. In fact, in this country, dentists are very expensive. And I was talking about this case with a colleague of mine. You hardly refer to a dentist in this country because they are expensive. So at this point, you would ask the consultant to come in and take a look at the mouth sore of the patient. In the event you get a patient who has run away, say you're in the NHS hospital and you walk in and they tell you find a nurse who tells you, the patient has absconded. What does this mean? It means that the patient has run away. That's the word they use here. I was looking at some websites about challenging patients in the NHS, and it's a frequent thing for people to just pick things and to run away. So before you jump to any conclusions, you want to go through like a process. Okay, have you checked? Thank you very much, nurse, for letting me know. What was the patient here for? He was receiving antibiotics for this, or he was getting heparin for a clot, and he just picked up and ran. Was he dissatisfied with the care? Had he mentioned it to somebody before? Let's check the room. Did you check the room to see if he's there? Does he have a roommate in the room? Does the roommate know anything about it? Okay, we need to find out if was he scheduled for any procedures? Did he go to radiology, ultrasound? Is he at physical therapy? Okay, then let's okay, have you called his family to find out if he's here, so that you are going through a process before you say, okay, I'm going to notify my seniors. Especially the bit about, I'm going to call his family, find out if he's home, and if necessary, then we would notify the authorities if he's a patient who's at high risk, if he's a confused patient. Maybe one day you might see this in the NHS hospital. But anyway, I'm looking at the time now. Somebody's asking the cage questions. What are they? These are for just for alcohol. You want to find out whether they have tried to cut down. Do they take like an opening, an eye opener? But I would never ask the cage questions back to back to back. I would, if I was going to ask them about cutting down, I would say, okay, doctor. Doctor asks, how much alcohol do you drink? I drink 10 pints a day. Okay, this is on the higher side. Does it seem like it's on the higher side to you? Because you want to assess. Maybe they don't find it, it too much. Then you ask, did you start drinking alcohol at this level of 10 pints, or did you increase the dose? Did you increase your amount of alcohol regularly? Over what period of time? Have you thought of cutting back? So, like, such questions, you never ask them back to back to back. Do you feel guilty? Do you have no? Okay. Have you had any withdrawals? From alcohol? Like vomiting or shaking? Okay, all right. Then when do you drink alone? So I'm asking many questions and I'm putting the cage in there. At what time do you drink? Do you usually drink in the morning? Do you drink at night? Do you drink during the day? Do you find it better to drink more alcohol than water? Is it your favor? Is it your drink of choice? And then you say, have you ever felt guilty about the amount of alcohol that you use? Are you interested in quitting at this time? Because at the level that you're drinking, you may experience some side effects of the withdrawals, and we would like to be able to monitor you at this point. If they don't want, then you never, even with smoking, if you ask them, would you consider smoking? I never say, do you want to, would you consider quitting? I never say, do you want to quit? I always add these nice words before. Would you consider quitting or cutting back? And if they say, no, I'm not interested, then you say, okay, whenever you're ready, we are here. And we have smoking cessation clinics that would be ready to walk you through the process. So you've given them the alcohol or the smoking counseling, even if they didn't want it. So I don't want to talk about smoking. Okay, when you're ready, then we can always revise this, because when you're ready, we can talk about it, and we have the appropriate groups for it. All right, guys. Our time is up. We have taken a few minutes after 8, but I'm going to make this video available for you. And if you have any questions, maybe next time you can just put them half an hour before the Zoom session starts. That way I can be able to answer them. But thank you very much. We'll continue to help each other through this process. And I wish you a good night.